why it's a problem. So consider a patient, Mrs. Jones, who is having peripheral vascular surgery or surgery on the blood vessels of her legs. And part of the protocol of that procedure is to receive prophylactic antibiotics to prevent infection postoperatively. And these antibiotics are given preoperatively. And suppose postoperatively she develops a rash because she's developed an allergy to that antibiotic known as cefazolin. And diligently, the clinical staff records that allergy into our inpatient electronic medical record, which is from Cerner Corporation. Now, suppose that a year later, Mrs. Jones develops a cellulitis on her lower extremity that's unrelated to the surgery. She visits her primary care physician, but this allergy information did not make it to Epic because these two systems do not share data and cannot share data out of the box. And without that allergy information, unless the patient tells the doctor elicits that information on history, she may prescribe Keflex for that allergy and not receive any kind of warning or alert from the order entry system in Epic. And if the patient then were to take that medication, she would obviously have an adverse reaction, possibly anaphylaxis or death. So here is one of the key patient safety issues we were trying to address. Now, suppose we have the ideal state and our semantic interoperability platform is in place. Once again, Mrs. Jones has the reaction in the hospital and the allergy gets entered into the inpatient medical record. But now when she shows up with cellulitis a year later and visits her primary care physician, the allergy information has made it into Epic due to the interoperability project. And not only has it made it into Epic, but it's made it into Epic in discrete form or structured data so that the alerting system in Epic can detect the allergy to cephalosporins and alert her that the patient is allergic to cephalosporin antibiotics and that she should prescribe something else for the cellulitis. So with that background on the problem with the lack of integration, now I'll move on to sort of some of the technical challenges around doing the integration. So at UPMC, our information technology or informatics environment is extremely large and diverse. So we have over 600 electronic systems or information systems, including 4 electronic health records or electronic medical records from 3 vendors. And that was 5. We have, since the project began, merged 2 of those into 1. We have a whole suite of ancillary systems, including laboratory, pathology, radiology, registration, admission, discharge, transfer, transcription, and on down the line. We have a picture archiving and communication system. We have an enterprise master person index, and we have a whole host of systems that manage financial issues around billing, care management, claim submission, and so on and so forth. So the challenge then is to bring all those systems together, but also we want to integrate. We have critical information about our patients outside our organizational walls. We want to get laboratory data back from commercial laboratories with whom we do business. We want to maintain good relationships with all our affiliated physicians and accommodate electronic exchange of information with them to the extent possible. Also, in addition to our own health plan, we want to connect with the other payers in the region and receive claims data to know, for example, that patients actually filled their prescriptions after they were written in Epic or Cerner. We want to connect with patients. With the personal health record, we want to be able to capture data from them in the personal health record and make that available to them and accommodate even simple things like prescription refill requests and allow them to request appointments. And finally, a big initiative ever since the Office of the National Coordinator of Healthcare Information Technology was created at the federal level is health information exchange with other providers and hospitals, physicians, freestanding diagnostic imaging centers, and so on down the line in the region. So now we have another quick poll to see if these issues jive with some of the things you're facing at your organization.
So the question that Bill is asking here is, are you facing similar problems with fragmented information? If you could type or click your response here. Okay, so Bill, looks like the overwhelming response right now is yes. Right now, around 88% of people are yes, and 12% of people are no. So it
I'm glad.
seems like this is a challenge that's resonating well.
Good. That's good to hear. I'm glad you're still with me. So at UPMC, the solution we adopted then was build a semantic interoperability platform with the goals of creating a comprehensive record, collecting data once and reusing it often, harmonizing the semantics to support clinical decision support, by which I mean support for the clinician who's making the decisions for patient care at the moment. So rules and alerts, drug allergy checking during order entry, drug-drug interaction checking during order entry, order sets, and so on and so forth. So you need the semantics to support that across diverse information technology environment and multiple electronic medical records. Business intelligence, by which I mean the analytic reporting for quality initiatives, PQRI, even just managing your own, even just decision support for your leadership so that they can have a good handle on the business and what their cost drivers are and how to address them. We also want to provide clinically relevant displays, even with the meaningful use criteria. The federal government starting to look at usability issues, and as I'll show you, semantics can go a long way to help you address usability issues of the data with your EMR. And we went through a process through which we selected DB Motion as our vendor partner to build this semantic interoperability platform. But once we selected DB Motion, we had to decide where to begin. The whole problem is not possible to solve immediately. But we had executive pressure to demonstrate early value, and we also wanted to gain confidence of our end users. So it seems like an insurmountable challenge when you set out to do it, and the question is there a high-value early win to be obtained that can keep momentum going and sustain the effort long-term? So our strategy to address that challenge is as follows. First, we defined a pilot user group, and we also define data of high value. Now those two things interact with each other because depending on who your users are, they'll find different data of high value. And I'll talk about who our pilot users were and what data we thought they would find of high value on the next couple slides. You also have to figure out how to deliver the integrated information to them. Ultimately, you would like it to be with as close a match to their workflow and integrated into their workflow as possible, and I'll talk about some of those challenges as I go through the presentation as well. And finally, we wanted to demonstrate early the benefits of the semantics. And again, I'll go through the issues of semantics and how we address them and what the benefits were as we go through the presentation. So with respect to defining our pilot user group, we initially selected emergency room physicians as our largest pilot user group, and the main reason being that they're at the interface between the inpatient and outpatient setting. They use the inpatient EMR, but they get a lot of patients from our outpatient clinics where the data about medications, allergies, and problem lists are not available, especially in the emergency room in some of our core academic and community hospitals near downtown, where most of our electronic medical record in the outpatient and inpatient setting has been implemented. We also wanted to implement with outpatient physicians who were going to be at the opposite side of the transition of care after patients had been discharged from the hospital, so that they could see discharge medications and get allergy data that, per the example I gave, the illustration I gave earlier, any allergies the patient developed in the hospital. And as I'll explain later, we found a number of other groups of users, not all of whom I've listed here, that found the system useful, including radiology department staff, operating room staff who were doing preoperative surgery clearance, And also nurses and physician extenders in the emergency room also found